Maybe she's not a topper in class. Yet, she's not the one to stop trying. Maybe she didn't get that position. Yet, she's not the one to slow her pace. Maybe her body is besieged with ailments. Yet, she's not the one to give up on life. There's no stopping her, even with thyroid troubles. Eltroxin, championing women since 1950.
Good afternoon, everybody. Welcome to today's program. I'm Dr. Pratik Tambe, Chairperson for the AMOG's Endocrinology Committee. A warm welcome to all our distinguished stalwarts and eminent faculty who are here for today's event, as well as to our audience who are logged in from across Maharashtra and the rest of India. We have a fantastic academic program in store for you over the next couple of hours. But before we begin the proceedings, I would like to start by offering my gratitude to our AMOG's office bearers. Our president, Dr. Nandita Palchetkar, Madam is the current president of AMOG's, the immediate past president of FOXI. She's also served as the president of the Mumbai Society and IAG in the past. She's currently the vice president of ISAR as well. Thank you, ma'am, for your blessings, your guidance, and also for being a shining beacon for all of us juniors who follow in your footsteps. Next slide, please. I would also like to express my gratitude to Dr. Arun Nayak, a fantastic vaginal surgeon, a distinguished academician, and also the secretary of AMOG's. Thank you so much, sir, for your blessings always. Next slide, please. At this juncture, I'd like to express my gratitude to the ICOG office bearers, our chairperson of ICOG, Dr. Uday Khanawala, the secretary of ICOG, Dr. Ashok Kumar, for granting us the ICOG credit point for today's event. Thank you so much for your support and your guidance. Next slide, please. I would like to, at this stage, introduce our chairpersons for today. Dr. Rajendra Singh Pardeshi. Sir is the vice president of AMOG's. He has also served as the vice president of FOXI in the past. He has been somebody who is well known for working hard and coming up the hard way. Also served as the president of the Aurangabad OB/GYN Society in the past. Several best paper prizes at AICOG conferences to his credit. Thank you so much, sir, for your blessings and guidance always. Next slide, please. We have with us Dr. Parul Kotadawala, sir. Sir is the vice chairperson of ICOG. He has also served as the vice president of ISOPAB, vice president of FOXI in 2006, president of SOVOG, and president of the Ahmedabad Society way back in 2007. He is also the India coordinator for the International Adhesion Society and a fantastic endoscopic surgeon in his own right. Thank you so much, sir, for joining us today. Next slide, please. We are also privileged to have with us the second vice president-elect of AMOG's, my dear friend, Dr. Amey Purandare. Sir is a consultant at several hospitals in South Mumbai. He served as the joint secretary of FOXI in 2019, also as the chairperson for the Food, Drugs and Medico-Surgical Equipment Committee of FOXI, assistant administrator for the FOXI Manyata project, and managing council member and a mentor for the MOGS Youth Council. Thank you so much, sir, for being with us today. Next slide, please. We have also a very distinguished gentleman in the shape of Dr. Rahul Madi. Sir is the president of the Navi Mumbai OB/GYN Society, a consultant at the Mathadi Hospital Trust, and president of the Navi Mumbai Society, as I just said. He's an associate medical legal consultant and also a member of the Ethics and Medical Legal Committee of FOXI. Sir is also a lead assessor for the FOXI Manyata project and a member of the State Oversight Committee for HIV and AIDS, somebody who we look up to and somebody who has served several positions in the Navi Mumbai Society over the past several years. Thank you, sir, for joining us today. So we have a fantastic scientific program. Session, you can stop sharing. We have a fantastic scientific program with four eminent stalwarts from various different parts of the country. Dr. Ragini Agarwal, Vice President of FOXI, immediate Vice President, past Vice President, I should say now. We have Dr. Krishnendu Gupta, sir, who has also served as chairperson for the FOXI Endocrinology Committee once upon a time and as the chairperson of ICOG very recently. My dear friend, Dr. Rajendra Nagarkatti, who is the chairperson for the AMOG's Midlife Management Committee and immediate past chairperson for the same committee of FOXI. And a dear friend, Dr. Sandhya Saran, the president of the Thani OBGYN Society, who will be delivering a talk as well. So before we start the scientific proceedings, I would like to take this opportunity to introduce our guest of honor for today, who is none other than the dynamic, talented and dashing lady who goes by the name of Dr. Kavita Bapat. To introduce her formally, she is the Vice President of FOXI currently. She is the organizing secretary for a fantastic conference called as AICOG 2021 Indore, which is going to be held in January of 2022. And we look forward to that great event as one where all of us finally probably will be able to meet physically after 2 harrowing years that we have spent in this COVID lockdown and pandemic. She's also served several different organizations, executive member of ISAR and IAG managing committees. She is the president of the MP chapter of Vaginal Surgeons, secretary of the MP chapter of IAG. So many distinguished awards to her credit. Over to Dr. Kavita Bapat. Please bless us with your words of wisdom.
Thank you so much. Thank you so much as usual. I'm really happy today that the AMOG's Endocrinology Committee is perfect. And Pratik, as the GSK's word is, there is no stopping for her. Especially for you, it's no stopping for you over here. I'm finding you I think the whole year or two, you are just non-stoppable person and you are making the dent into the OBGYN and everywhere. So really congratulations and especially very much appreciated this point. And I'm happy today the chairpersons are 3 chairpersons again sabke aage vice laga hua hai. So me vice president, FOXI vice president AMOG's is Dr. Rajendra Pardesi, my mentor, my friend, everything. Vice Chair ICOG Parul Kotadawala, Vice President again, elect AMOG's. So really nice to have Ame Purandre and Rahul Vani as a president today, as a chairperson. But all credit goes to you people all that you are having the awesome speakers today. And the endocrinology committee gets full marks when they talk about diabetes, when they talk about thyroid, they talk about the midlife transition, and when they talk about the UTI. And the profound speakers you have from my dear friend Ragini, the person whom I admire most, and a friend of mine, Dr. Krishnendu is there, a darling friend of mine, Raju is there, and Sandhya, you are a newer in the stage. So I wish you all the best, and I'm sure the audience will get the maximum benefit from the speakers, profound speakers like you all. So thank you once again, Pratik, and the TOG again, thanks to them also for inviting me today. Thank you so much. Thank you so much, and all the best for this webinar.
Thank you very much, ma'am, for gracing the occasion and your wonderful words of wisdom. We look forward to seeing you physically at AICOG Indore. And
I always get an opportunity to invite you all to come to Indore. Let God make us things the way we want it, and really we pray for that. Thank you so much.
Thank you so much, ma'am. With that, we will start the scientific proceedings. We have with us Dr. Rajendra Singh Pardeshi, sir, who is our Vice President of MOX. I would request, sir, to please introduce the first speaker of the day, Dr. Ragini.
Hello, good afternoon, everybody. Chief guest, Dr. Kavita Bapat, ma'am, and all dignitaries. We would like to invite Dr. Ragini Agarwal, ma'am, for the next talk on the modern management of GDM. I think Dr. Ragini doesn't need any introduction. And she is the right person to guide on management of GDM. To introduce her, she is fellow clinical gynec endoscopy UK master course cosmetic gynecology and laser academy of aesthetic medicine, clinical director of gynae and MAS head department of cosmetic gynecology and pelvic reconstructive surgery, senior consultant Then Vice President Foxy 2020, founder of Gurgaon Gynae Society, founder president of Haryana OBGYN Society, president elect, all president Indian Academy of. Madam, just we wish to introduce you.
सर आप म्यूट हो गए हो डॉक्टर परदेसी अब म्यूट हो
Yes, host is not allowing me video, I don't know why. So to introduce, the main introduction is she was chairperson of Food and Drugs Committee. She has done amazing work and she was vice president also, and she is right person to guide us on modern management, not only tablets, injections, means oral hypoglycemic agents and all that intraparental, but in nutritional also. So I would like to request again Ragini ma'am. Thank you so much.
Thank you so much.
Ragini ma'am, over to Dr. Ragini.
Thank you so much. Let me, Wow, this is something magic. Very good afternoon to all of you. Thank you, Pratik, for giving me this opportunity to be again part of AMOX, which is really, I think, a very, very great honor to be a part of AMOX faculty and sharing the knowledge with you all and all the viewers. Thank you so much for joining and sharing your time with me. Gestational diabetes, we all know that it is one of the very common endocrinal problem among the pregnant women. With the blessings of Mahakal, I will start my presentation. When we talk about the diabetes or any condition which is directly related with your lifestyle.
Dr. Ragini, I'm sorry to cut in. We can't see your slides, madam. May I request you to kindly share?
I'm sorry. Okay, now it's okay. Hello?
Yes, madam.
Yeah.
Yes, ma'am, please go ahead. Make it full screen if you can, please.
Okay. So if you are brave enough to say goodbye, life will reward you with a new hello. That is our GDM. If we really change our lifestyle, we can only have a wonderful life with the diabetes or GDM for our kids. So improving maternal health and reducing childhood mortality are two of the United Nations 8 Millennium Development Goals. And they represent a unique or daunting challenge for the healthcare providers worldwide. Focus its effort on the reduction of the NCDs and the exposure in pregnancy to improve the future health of the woman and their offspring. So understanding the management of the GDM since starting of the pregnancy, even a pre-conceptional, it is very, very important. Now the new word for the GDM is the hyperglycemia in the pregnancy. And 1 in 6 live births are to women with some form of hyperglycemia in pregnancy. When we talk about the hyperglycemia in the pregnancy, that is diabetes in pregnancy or gestational diabetes mellitus. Now, this gestational diabetes mellitus is today considering both things, whether it come up during the pregnancy or it is pre-existing. No more the pre-existing diabetes mellitus word is used. But just for the understanding, this chart is presented here. There's a difference between two people in the diabetes in pregnancy, which is pre-existing, is basically it can be a type 1 diabetes also. Where otherwise, the gestational diabetes mellitus, which is only coming during the pregnancy, is mostly type 2 diabetes. The pathophysiology of the GDM is not fully understood, but it has been linked to the hormonal imbalance affecting insulin sensitivity and pancreatic B cells dysfunction. So what is the difference if we think if patient is having a diabetes in pregnancy as a pre-existing thing? That means high chance of the congenital abnormality, and we have to discuss it with the patient, specifically if there is a higher HbA1c, whether they want to continue pregnancy or not. But we are nobody to offer any abortion on the only basis of a diabetes in pregnancy or a higher HbA1c. And this GDM hyperglycemia during pregnancy, that is not diabetes, is basically first time diagnosed in pregnancy and may occur at any time during pregnancy, mostly after 24 weeks. Prevalence corresponds with the prevalence of the impaired glucose tolerance and the type 2 diabetes in any given population. And we all know that today, with the epidemic of the PCOD, IGT is very, very common. In obese, even the obesity is increasing. So many girls who are becoming pregnant, they are having an impaired glucose tolerance already, which can precipitate as a GDM. Other thing is early onset of diabetes because of these features of the pre-diabetic. Then increasing age of the childbearing, there's an increasing obesity leads to a vulnerable to the hyperglycemia. So what we are going to target? The goals of the early intervention are not only to improve future maternal health, but also to reduce disease prevalence in the subsequent generation. Pregnancy is often described as a window of future health because the pregnancy is a stress test and many women seek medical care during their pregnancy. And we all know that intrauterine environment is going to influence the health of the offspring. Intrauterine and early infant environments have a permanent conditioning or programming effect on the body's metabolism and health later in life. So GDM is an important determinant of the development of type 2 diabetes in both mothers and the offspring. So achieving glycemic control of during pregnancy may provide a window of opportunity to prevent and lower the burden of type 2 diabetes many generation. What is a recommendation? The fasting and postprandial self-monitoring of the blood glucose are recommended in GDM. And some women with pre-existing diabetes should also be test blood glucose pre-parentally also. So what is the target? FBS we will target is less than 95, 1 hour blood sugar less than 140, and 2 hour blood sugar is less than 120. Although it is very different when we go to the HAPO or ADA recommendation, but we have to follow this recommendation because WHO and the government of India both recommended this values for the Indian population. Due to the increased red blood cell turnover, A1C is slightly lower in normal pregnancy than in normal non-pregnant women. So ideally, what we think of the HbA1c in pregnancy is less than 6%, but relax to be up to 7% if necessary to prevent the hypoglycemia. But continuous glucose monitoring and self-monitoring of the blood glucose is very, very important. And not only this, if we are continuously have an eye on the glucose monitoring, only then we can reduce the macrosomia and the neonatal hypoglycemia in the pregnancy complicated by the type 1 disease. So what happened? The placenta secrete the tumor necrosis factor, human placental lactogen and human placental growth hormone. On the other hand, there's an increased estrogen, progesterone and cortisol contribute to disruption of the glucose insulin balance. And these all lead to a progressive insulin resistance develops during mid-pregnancy. So either there's an increased insulin secretion from the pancreas to compensate it, or if pancreas is not efficient, it will lead to a gestational diabetes mellitus, or there's an increased maternal adipose deposition or decreased exercise, increased calorie intake. All this along with the existing insulin resistance leads to a gestational diabetes mellitus in a patient. So in early pregnancy, there's an insulin secretion increases while insulin sensitivity is unchanged, decreased or may even increase. But mid-pregnancy, insulin sensitivity starts to decline progressively, and in late third trimester, there is a burst, and that's why especially GDM usually develops in the late second trimester or disappears instantly post-delivery. So that's the reason why achieving it is very, very important, because there's a lots of complication when we talk about the maternal complication like preeclampsia, type 2 diabetes in future, recurrence in the next pregnancy, increased operative delivery, and fetus also. We all know there's a lots of problem occur in the baby like congenital abnormality, macrosomia, risk for shoulder dystocia, preterm labor and stillbirth or even neonatal. That is very, very traumatic. It doesn't stop here. It will go towards the neonatal complication like hypoglycemia, connectors, bacterial infection, NRDS, birth trauma, to adulthood complication like they are more prone to obesity and increased risk of the metabolic disorder, including CV disorder and the insulin resistance. So the influence of the environment in the utero in the programming of the metabolic disease in the offspring. We all know, according to the Baker hepatitis, we have to understand the pathophysiology of the GDM and the mechanism of the fetal programming. And only then we can educate our patient very properly, because it is very, very difficult to educate them not to eat sweets, not to eat heavy foods during pregnancy, because everybody is there, what happened to the baby. So universal screening is the first thing when we are going to manage. The DIPSI test is Government of India approved DIPSI test. We have to diagnose in time, and our first focus is always is maternal nutritional therapy. And if it is failed, then only we need to the pharmacotherapy. And our goal is to achieving glycemic targets in the GDM. All women with GDM should receive nutritional counseling. That is must, and for that we as a gynecologist should understand the nutrition counseling, and first counseling should go from us. They should not be forced to go to the diabetic counselor or the educator or the dietitian immediately, because they don't have a faith. Then they have came to you. It is your duty to understand, because it is a therapy. Self-monitoring of the blood glucose is a must. You should go give them a chart, and they should religiously do the self-monitoring of the blood glucose. Increased physical activity to moderate intensity level is important. If blood glucose level cannot be maintained in the therapeutic range, then pharmacological therapy should be initiated. So what is the optimal approach? Optimal approach to glucose monitoring has not been determined completely how you have to do, but how I do when initially diagnosed with the GDM, a patient keep a journal of their food glucose level and fasting, and 1 or 2 hours after the each meal, she has to do it. And not only that, if blood glucose level is high, she has to write what she has eaten at that time. And every time when she visits me, I properly go through that journal and see and comment. Multiple daily measurements are the key to recognizing women who should begin treatment with an anti-hyperglycemic agent. The findings should be regarded in a glucose log register along with the dietary information, as I have told you, and this facilitates the identification of the glycemic patterns and helps immeasurably in interpreting results stored in the memory of the modern records. So, insulin should be added if needed to achieve glycemia, and other oral and non-insulin injectable glucose lowering medication lack long-term safety data, specifically before 20 weeks. So the majority of women achieve glycemic targets with nutritional therapy alone, and 30% will require supplementary treatment. What is important is the lifestyle behavior changes. Then insulin is the preferred medication, and metformin should be discontinued by the end of the first trimester. If you are giving to a patient of the PCOD, you can start metformin only after the 20 weeks or in the selected cases where the patient is not ready for the insulin. So I will just give a little detail of the maternal nutrition therapy, because if you are serious about it, you are 18%, more than 80% women going to be controlled only on the MNT. You don't require any other things to give them. It is a process by which the dietary plan is tailored for patient with diabetes based on the medical lifestyle and the personal factor. What you have to see: adequate calorie intake to promote fetal and neonatal and maternal health, achieve glycemic goals, promote weight gain, and prevent ketosis. Minimum 175 gram of the carbohydrate, a minimum of the 71 gram of the protein, and the 28 gram of the fiber is a DRI. Diet should not be high in the saturated fat, and the amount and the type of the carbohydrate will impact the glucose level in patients with the diabetes. So what is the principle? Healthy eating during pregnancy is very, very important. That means a carbohydrate controlled, balanced meal plan. The importance of the individualized nutrition assessment in the GDM is very important. according to the BMI, percentage of the desirable pre-pregnancy body weight, or optimal pattern of the weight gain during pregnancy. When we talk about the calories, individualization is very important. Energy requirement during pregnancy includes the normal requirement of the adult along with the additional requirement of the fetal growth. It does not increase in the first trimester unless a woman is underweight. Energy intake should be adequate enough to provide appropriate weight gain during pregnancy. And as per Indian ISMR guideline, average weight gain of 10 to 12 kg in addition to 350 kilocalorie per day above the adult requirement is recommended during second and third trimester. Severe calorie restriction is not recommended. It may result in the ketonemia, ketonuria, and impaired physical and mental development. So how we calculate that the energy requirement is BMR into PL, and BMR is for adult females is around 14 into weight in kg plus 471. And for the general, if you don't want to go in so much of the calculation, it is more for a research purpose. The sedentary worker have a 1900 plus 350 calories. For a moderate worker, there's a 2230 plus 350 calorie, and the heavy worker 2850 plus 350 calorie is a total energy requirement. So when we see along with the weight category, underweight, if BMI is less than 18.5, they should have a 35 to 40 kilocalorie per kg per day. If normal weight, it will be around 30 kilocalorie. Overweight to obese is somewhere 22 to 25 kilocalorie. But hypocaloric diets in the obese woman with GDM can adversely impair fetal growth. Always remember this thing. This is very, very important. Please don't restrict their calorie, because sometimes these women, they think, I will not take the medication, I will restrict their our diet. It should be properly explained to them, because a certain amount of the calorie is needed to you. If you don't take it, it is going to affect the baby. So for the morbidly obese woman, if the BMI is more than 40 kilogram, then it is intake is 12 to 14 kilocalorie, but it is prudent for obese women even to consume a minimum of the 1800 kilocalorie per day to prevent the ketosis. How you are going to distribute this calorie? Carbohydrate is around 40%, protein for 20%, fats is 40%, and you have to keep the saturated fat low by less than 7%. So type and amount of the frequency of the carbohydrate intake has a major influence on the blood sugar readings. One should take 3 small meals and 2 to 3 snacks each day. 1 serve of the carbohydrate is around 15 grams of the carbohydrate. So your patient should know when they are going to eat, not as a bowl, but as a raw material, how many grams of the chapati, of the atta they are going to make their roti. Around 30 grams of the cereals they need to make their roti, or 40 grams of the pulse they need to make their bowl of the dal. So saturated fat intake like ghee, butter, coconut oil, red meat, organ meat should be less than the 10% of the total calories, and the dietary cholesterol should be less than the 300 milligram. So the thing is that we can only say that trim the fat from your diet. If you are making anything, if you put the 2 spoons of the oil, take 1 spoon of the oil out of it, even if you're cooking the meal for everyone, or you cook for yourself separately. Coming to the protein, that is very important, and it is very difficult to give the protein to a woman who is not eating eggs and not eating non-veg. So you have to discuss this protein requirement in detail with them, because it is really, really needed for the fetal growth. Otherwise, it will take it from their muscles and they will develop more of the backache and everything. At least 3 servings of the protein foods are required every day to meet the increased demand. Source of the protein, we all know that the milk, egg, fish, chicken, pulses, nuts, but whether they are taking in the adequate amount or not, it is very, very important. So it promotes satiety, slow the absorption of the carbohydrates, provide adequate calories, and a bedtime high protein snack is sometimes needed in order to prevent accelerated overnight ketosis process. A very good bedtime high protein snack is a mixture of the nuts. So these small things, it goes from you to them. It has a really very big value. High fiber foods, Then fiber is also very important because we need that the fiber helps the digestion and prolong the absorption of the carbohydrate, delay the gastric empty. So the entry of the glucose in the bloodstream is reduced. Soluble fiber in the flaxseed, psyllium husk, oat bran, legumes, pectin from the fruits and the root vegetable are helpful. So how you are going to manage pregnant women with the GTM? First, you do the MNT with the physical exercise for 2 weeks. Do the PPBS. If it's still less than 120, continue the same thing. If it is the more than 120, you have to start the OHA or the insulin therapy. Exercise is really important because it gives a special effect to reduce the blood sugar and very helpful, and patient can continue with the exercise till the end of pregnancy. And there's no medical or obstetrical contraindication, like if she's a heart patient or she's having a low-lying placenta, she can continue all type of a physical activity, exercise. So coming to the pharmacological therapy, insulin supplementation may be necessary to achieve euglycemia. The ATO also states that the metformin should not be used in women with hypertension, preeclampsia, or at risk for the IUGR due to the potential for growth restriction or acidosis in the setting for the placental insufficiency. And we all know the many times these GDM babies, there's a placental insufficiency because of the vasculopathy and they are the IUGR baby. Here we have to be little careful for giving the OHA. So we all are, as a OHA, mostly we are giving the metformin, not the glyburide. So I have focused mostly on the metformin. So it is an accepted medical management of the pregnant woman with the GTM, not control on the MNT. Insulin is the first drug of the choice, and metformin can be considered after 20 weeks of the gestation for medical management of the GDM. Insulin can be started anytime during pregnancy for GDM management. If pregnant woman with GDM before 20 weeks and MNT failed, start insulin. Metformin can be started after 20 weeks if MNT failed to control her blood sugar. If the woman's blood sugar is not controlled with the maximum dose of the metformin, that is 2 grams per day in a divided dose, and MNT, again you have to add the insulin. So the dose of the metformin is 500 milligram twice daily, only up to a maximum of the 2 grams per day. And it is very necessary when you start a metformin, tell them they will see for any cramps or any pain in abdomen or any dizzying spell, and accordingly they will report also, and it will always followed by a meal when they take a metformin tablet. It should not be they have taken a metformin and taken a food after 2 hours. Hypoglycemia and the weight gain with the metformin are less in comparison to insulin. If insulin is required in high doses, metformin may be added to the treatment. So it is very, very individual treatment, and it should be followed daily, especially a patient who is on the insulin. She should have a number on which she can phone at any time and can be in touch of the doctor or your counselor or your diabetes educator, at least with her chart, not daily, but at least weekly. So insulin is a preferred agent, and the dose of insulin varies in a different individual because of the varied rates of the obesity, ethnic characteristic, degree of the hyperglycemia, other demographic criteria. How you are going to start? The moment a patient comes, there should be a basic dose. The basic dose is 0.7 to 2 units per kg. And to achieve the glucose control, the dose and the type of insulin used is calculated based upon the specific abnormality of the blood glucose noted during monitoring. Usually in the night time, we have to give the long acting, and accordingly we have to add 1/3 and the 2/3 of the insulin, and the watch is very, very necessary. Anyone who is not very, very comfortable with giving the insulin, it is not a problem if you take the help of your medical colleague or endocrinologist colleague, because it's the time of the multidisciplinary approach. So the physiology of the pregnancy necessitates frequent titration of the insulin to match the changing requirements and underscores the importance of the daily and the frequent self-monitoring of the blood glucose. None of the currently available human insulin preparation have been demonstrated to cross the placenta. The special concern which should always be in your mind is the two things, hypoglycemia and the ketonuria. Hypoglycemia, and you have to educate your patient about them. Always tell them they have to keep a glucose ready with them, and they should carry a tag with them that they are the GDM patient and they are on the insulin in their purse if they are going anywhere alone, as we give to our diabetic patient.
Dr. Ragini, just
two slides left. To achieve the goal, the education, self-family, support group, self-monitoring, and the more frequent visits are necessary. Always remember the medical legal consideration. So whenever you give the metformin, always remember when not to give, and only give to the women who decline the insulin therapy, and they should understand the limitation of the safety data and the possibility of the insulin supplementation may be necessary to achieve euglycemia. To conclude, the most important step to proper management of the patient is to unify all the screening methods, and multidisciplinary team is important. Universal screening is a necessity, and adverse events on the fetus were positively correlated with the A1C level. First step in treating GDM is diet, and only 30% of the targeted plasma glucose level are skipped. Then start the pharmacotherapy. Insulin is first choice. High prevalence of the GDM is a major obstacle to achieve improving maternal and the child health. So GDM, although it is a transient condition, is equally are lifelong. Gravity of the GDM and challenges to its management, including identifying and overcoming risk factor, accurate diagnosis, treatment of the disease in order to prevent associated complication is of paramount importance. So tell and I forget, teach me and I remember, involve me and I learn. That is the thing with your patient. Until unless you involve, you cannot control the GDM properly. Thank you so much for your patient hearing. My thanks and gratitude to all articles where I have taken the material. Thank you so much, everyone, for your patient hearing.
Thank you, Dr. Ragini. It was really an excellent talk. Actually, she has explained nicely from starting for the prevalence of GDM and problems we are facing as a obstetrician, antenatally, intrapartum, and to baby also. And started when to start oral hypoglycemic agents and when to start insulin. And basically, as she was successful chairperson of Food and Drugs Committee, and it was reflected in this topic because medical nutrition, she has stressed on medical nutritional therapy. And that is a really important. Thank you so much.
Thank you so much for your kind words.
Thank you, Dr. Pardeshi sir and Dr. Ragini Agarwal. Can I request Dr. Amay Purandare sir to please introduce Professor Krishnendu Gupta?
Thank you, Pratik. It gives me a sense of great pleasure, pride, and privilege to be introducing the next eminent faculty for this afternoon's webinar. First of all, I'd like to thank Dr. Nandita Palshetkar for instituting this webinar and Dr. Pratik to so excellently executing them. So friends, we have Dr. Professor Krishnendu Gupta as our next speaker. Professor Krishnendu is very well known across the OBGYN circles, not only in India, but he is an international clinician of repute. His biodata is extremely exhaustive and extremely splendid and stellar, but the key points include that he is the professor and unit head of the Department of OBGYN at the Vivekananda Institute of Medical Sciences, Kolkata from 2002 till date. He is also the adjunct professor at the Department of OBGYN at the famous Kasturba Medical College at Manipal from 2017 till date. Dr. Gupta is the FOGSI representative to the AOFOG for the tenure 2020 to 2022. He's also the current chair of the Sexual and Reproductive Health Committee of AOFOG. He has been the chairperson of the ICOG in 2016, the president of the Bengal OBGYN Society in 2013, and the vice president of FOGSI in 2011. He has been a recipient of various awards, including the famous FRCOG from the Royal College, as well as the Fellowship of the Ireland College of Physicians. Dr. Krishnendu Gupta is often considered as a very good teacher and has received numerous gold medals during his excellent academic career. Personally, he is a friend, philosopher, and guide. And to put it in a lighter vein, he hails from the Vivekananda Institute and he is the Vivekananda of Foxy. So over to you, Professor Gupta.
At the outset, I'm extremely grateful, Ameya. You really make me extremely embarrassed with your very, very generous introduction. And you've done this once in the past, I remember, in one of our TOG meetings, and I had to literally look down. But thank you so much for this opportunity, and to Pratik as well. He's been really gunning for me, I should say, to speak in his webinars, and I really am grateful to him for the opportunity, and also to MOGs as well. So my topic, and I also, I'm grateful to all the delegates who, despite working day, has logged in. So I'm going to be speaking on thyroid disorders in pregnancy, and without further ado, I think let's get cracking on it. And we are all aware that pregnancy exerts a very substantial impact on maternal physiology, and thyroid is no different. So all of us should definitely have a clear-cut understanding of the dynamics of TSH, T3, T4 in pregnancy. Well, in early pregnancy, as we know, there is a decrease in the serum thyrotropin, and this is basically because of a TSH-like effect of the human chorionic gonadotropin, which is like a spillover effect, which kind of increases in the free thyroxine. And of course, we have certain questions that we should ask: is pregnancy actually a state of relative iodine deficiency? What is the role of estrogen and HCG in creating this hypo or hypothyroid milieu? Is HCG protective? The biochemical hypothyroidism in third trimester, why does it occur? And we all know that pregnancy is a state of relative iodine deficiency because there is increased placental uptake and transfer, there is increased maternal renal clearance, the placenta converts T4 to reverse T3, and we are aware of the normal requirements as far as the body, as far as thyroid is concerned in non-pregnant, pregnant, and lactational. We need about 150 mics and 175 mics and 200 mics of thyroxine to keep everything going. And the estrogen, there is a rise in the serum TBG, and there is an increase in the total T4 and T3. What is important is T4 and T3 often remain unchanged. So we are well aware the facts that TSH decreases in the first trimester, TSH increases in the second trimester, and that's second, third trimester, and that's the area where we have to be extremely careful. The total T3 and T4 rises, but the free T3, T4 is less altered. And these are some of the common thyroid hormone levels, pregnancy-specific values that we are all aware of. It's beyond the scope to go through every particular point, but we must look at TSH, which is extremely important in the first, second, and third trimester. Clinically, as you all know, we always like to keep the TSH at around 2.5 to 3, and despite, because we know that there is a rise in the TSH levels, especially in the third trimester. So thyroid is definitely a new age epidemic. We had another epidemic about which Dr. Ragini Agarwal spoke just before me, and it is the second most common cause of endocrine dysfunction in women of childbearing age, and hypothyroidism, as we all know, is more common during pregnancy than the hypothyroidism. So the questions which we often get asked is, how early would the developing embryo need thyroxine? Can pregnant women compensate for this increase in demand? What about the maternal thyroid profile in response to the pregnant state? Any inbuilt, are there any inbuilt safety devices? And there obviously requires a clarification regarding measuring FT4 and FT3 or total T4, T3. So we know that the fetal thyroid gland begins to form at about the 5th week of gestation, starts functioning at about the 10th week, and becomes autonomous at about 12 weeks. The fetal demand for thyroxine starts at 5 weeks. So what is important for us to remember is that fetus depends on the maternal thyroxine completely in the first trimester and partially till term. And the thyroid disorders, which are commonly seen as hyperthyroidism, hypothyroidism, there could be a goiter as well as a postpartum thyroiditis. We are not going to deal with it because it's beyond the scope of a 20-minute presentation. So let's talk about the less commoner of the two, which is the hyperthyroidism in pregnancy. And it complicates about 1 in 1,000 to 2,000 pregnancies. Overwhelming cause in pregnancies because of the Graves' disease. We all know it's an autoimmune organ-specific disease, usually associated with thyroid stimulating antibodies, and is seen often in the late first or early second trimester, where we have a third generation thyrotropin assay as well. And subclinical hyperthyroidism often leads to abnormally low TSH levels, but the thyroxine levels are usually normal. Well, coming to what are the possible causes of hyperthyroidism, we did mention about it just now. Timing in relation to the trimesters, discriminatory signs and symptoms to arrive at a diagnosis, confirmatory tests, maternal and fetal risk, and monitoring. The basic thing which you have to know is 90% of hyperthyroidism in pregnancy is caused by Graves' disease. And the other causes could be a diffuse toxic nodule or toxic multinodular goiter, subacute thyroiditis, Hashimoto's thyroiditis, which can also cause hypothyroidism, which I'm going to deal with, and trophoblastic disease. Well, the good part is that subclinical hyperthyroidism is not associated with adverse pregnancy outcomes usually. The treatment is unwarranted in pregnancy, as we all know that these anti-thyroid drugs can cause certain issues with the fetus and can reach the fetus. And it's very important that we just do, we are pretty happy with the benefit from periodic surveillance. But I will always, as Dr. Ragani said in the last presentation, that we are in the era of multidisciplinary approach. We always must involve an endocrinologist in these cases, because they are the ones who know the subject of endocrinology and thyroid and things much better than us. So it's better to involve them in every case. So there are suggestive findings like tachycardia, thyromegaly, exophthalmos. There's the patient just doesn't put on weight. And of course, as far as the lab diagnosis goes, there's markedly depressed TSH, elevated free T4, and very rarely do we have a case of very, very high T3 levels. The drugs are propylthiouracil and methimazole. Methimazole can cause rarely an embryopathy. Monitoring FT4 is better than TSH. All of us know that. And it can cause another issues like transient leukopenia or agranulocytosis. And clinically, if the patient starts having fever or sore throat, I think we better to discontinue medication and just do a run of a complete blood count, etc. Subtotal thyroidectomy is rarely done in pregnancy, and ablation, of course, is contraindicated in pregnancy. So the complications of hyperthyroidism is largely depends on the metabolic control. Untreated, of course, we can give, it's associated more with preeclampsia, heart failure. We know about the thyroid storm, the adverse perinatal outcomes like the fetal growth restriction or neonatal death. Neonatal hypothyroidism has been seen in about 2% of hypothyroid mothers, and that is because of the transfer of the thyroid stimulating immunoglobulins, which is basically IgG, and those who are obviously post-ablative and then gets pregnant later on. So the follow-up is very important, FT4 and TSH at 6 weeks, and we can have an aggravation in the first few months postpartum. Breastfeeding is not contraindicated. It's very important for us to know, and periodic evaluation of infant's thyroid function is important. Well, fetal thyrotoxicosis, as I said, can occur due to the placental transfer of the thyroid-stimulating immunoglobulins in utero, and of course, those who don't receive treatment. And there are various levels, various diagnostic criteria, like persistent fetal tachycardia, fetal goiter, etc. And the treatment is usually by propylthiouracil or a thioamide, which are available. And the main risk of therapy is, again, fetal hypothyroidism. So everything has to be balanced. I mean, it's really no point in going through a chart which is there in any standard textbook. Anyone interested can just take a screenshot, and we just treat hyperthyroidism in this wonderful algorithm, which is taken from one of the journals of endocrinology. Well, coming to the more commoner hypothyroidism in pregnancy, which we often see, it's almost like the progesterone womb to tomb kind of thing, simple to assess, easy to diagnose, economical to treat. And we know that it's a replacement therapy if required. So we have to give it for, especially for a very, very long time. And occurs in, it's a commonest, commonest is the Hashimoto's thyroiditis. And we all know that initially, when there is Hashimoto's thyroiditis, there is inflammation of the thyroid, which causes what we call as leak, which results in excess thyroid hormone. So that is hyperthyroidism. But then over time, the inflammation prevents the thyroid from producing more hormone. So therefore, you get hypothyroidism. So other causes are endemic iodine deficiency, ablative radioiodine therapy, and post-thyroidectomy patients. And subclinical hypothyroidism is something which we have to deal with, and we have to do these tests to find out. It's about 2 to 3% of pregnant women where we find elevated TSH with normal T4 levels, and screening and treatment, whether we need to do universal screening or not, is controversial. In my clinical practice, I always screen them. So it's my choice. I'm sure people may differ with that, but that is the way I think we can pick up these subclinical hypothyroidism. Well, this dietary deficiency is something which we have to think about, especially with hypothyroidism as well. Well, the complications, that's something which we are very worried about in pregnancy: gestational hypertension, placental abruption, preterm births. We are scared of spontaneous abortion, increase in stillbirths, and of course, if the baby is born, there is a chance of neurological dysfunction in the newborn as well. The suggestive findings of a patient is fatigue, constipation, cold intolerance, muscle cramps, dry skin, hair loss, weight gain, etc. And of course, the lab diagnosis: abnormally high TSH and abnormally low T4, and high T3 again is extremely rare. So replacement therapy is 1 to 2 mics per kg per day, or 100 mics per day. The serum TSH is usually measured at 4 to 6 weeks intervals to know whether we have to raise the dose or not. We adjust the dose in increments of 25 to 50 mics, although I often see the endocrinologists prescribing doses like 62.5, 88 micrograms, which I really have no clue. Sometimes they give it every alternate day. They give 100 micrograms for 5 days in the week, and the weekend 75. So whole lot of permutation combinations are seen. And but I think we as clinicians, as gynecologists, we'd like a steady dose, and we like to adjust them between 25 to 50 mics as and when we do the test. So we usually get them checked between 6 to 8 weeks, and of course postpartum as well. So we have to make a kind of a conscious decision to speak with the patient that these patients have a risk of clinical disease in 5 years, so we have to monitor them extremely. And of course, we don't stop breastfeeding at all. What are the tests for hypothyroidism, which I just discussed? When do we do the tests I discussed? Screening test for thyroid we did, and interpretation of thyroid function report. So who should be tested for hypothyroidism? Clinical suspicion of the disease, like symptoms, history of thyroid disease, family history, irregular periods, for prior history of infertility, pregnancy wastage, etc., obese, type 1 diabetes mellitus, and history of any autoimmune disease. When to do the test? Preferably preconception, but once in pregnancy, during the antenatal period, we must try to do it in the first visit if possible, but definitely between 12 and 20 weeks to pick up cases of the subclinical hypothyroidism. And what tests to do? As I mentioned, serum TSH, free T4, and other tests we can, of course, do are anti-TPO antibodies and antimicrosomal antibodies. TSH levels, we like to keep, as I said, between 2 to 4 all the time. If it's between 2 and 4, we are very happy. Anything more than 4, we have to definitely treat. And free T4 could be either in the normal range or low. And anti-TPO antibodies are replacing the microbial antibodies and antithyroglobulin antibodies. If it's positive and TSH is more than 4, we have to think about autoimmune disease. And if it's negative and TSH is less than 2, we obviously interpret it as normal. So other tests which we can do are lipid profile, cholesterol, of course, and sugars, oral GTT, and calcium. Calcium is important because hypothyroidism is known to affect calcium homeostasis by decreasing bone turnover and serum calcium levels, and by increasing the parathyroid hormone and 1,25 dihydroxyvitamin D concentrations. Similar with phosphorus, it has been shown that patients with hypothyroidism significantly have a diminished phosphocreatinine and inorganic phosphate ratio. And after substitutional therapy, we find that these levels return to normal in after about a few weeks of therapy. So that's why doing a calcium and phosphorus estimation would be helpful. And again, we have covered these: when should be tested, when to do the test, what are the tests, etc., and other tests like calcium and phosphorus. Well, subclinical hypothyroidism is something I would just like to briefly touch upon. There are no clinical signs and symptoms. We just find a raised TSH, normal FT3, FT4 levels, and most endocrinologists prefer to just treat subclinical disease. And so do I, especially those who are planning to get pregnant once pregnancy. If the levels are above 4, we would definitely want to treat and start supplementation as soon as possible. You can start with a very low dose of 12.5, the level about 3.5 or 4, and definitely work them up. As I said, do them every 6 to 8 weeks and work them up. And we have to know that about 2 to 3% of them do have subclinical disease. And that's the reason why we should check, because we want to be sure that we do not miss this problem, because we all know the problems of neonatal cretinism and as well as subtle neurodevelopment abnormalities in the fetus. Well, what are the risks and benefits? Is screening mandatory? That's a big issue, which I think is always up for grabs. The jury is still out. Ideal treatment modality we know is L-thyroxine, monitoring of the disease, screening of the newborn for hypothyroidism. Well, the risks, some patient will not benefit unless the cost, although the cost of levothyroxine is extremely low. Long-term stigma, you're hypothyroid and stuff like that. Iatrogenic hyperthyroidism, osteopenia, and of course, very, very rarely atrial fibrillation. So the benefits and an elevated TSH in this group of women should be treated when there's a possible association with high maternal TSH levels, and we can prevent these adverse neurophysiological outcomes. And of course, there are no interventional trials, unfortunately, assessing the benefits of T4 therapy of group, in various studies. The American Association of Clinical Endocrinologists recommends screening of all pregnant patients, or women, I should say. There's definitely a controversy over what is the best screening tool, TSH or FT4, and TPO screening is a must in subclinical hypothyroidism because we want to rule out the problem. And the American Thyroid Association recommends population screening after 35 years of age every 5 years. So that's another population-based kind of an advice. So the treatment is obviously thyroid replacement therapy, empty stomach early morning, drugs which should not be taken for 4 hours after a thyroid medication is iron, any antacids, things like lithium, of course, we don't give in pregnancy, cholestyramine and sucralfate. So this is, again, important for us to know that we should not give an iron tablet, immediately after a thyroid tablet. So we should monitor them, at least every 4 weeks to maintain a TSH level. Although 1 to 2 is a little more strict, I think we are very happy with the 2.5 to 3 level, and especially in the third trimester, where we find a quantum leap in the thyroid, in the TSH levels. So once euthyroid state has been achieved, it should be monitored, and until delivery. During pregnancy, of course, as I said, the thyroid function merits regular monitoring and fine tuning of the treatment. And I've already discussed about how to go about the therapy. We know it is safe in both pregnancy and during lactation. And patients, and what is important to know is patients who are on thyroxine treatment before pregnancy should increase the dose by at least 30% once pregnancy is confirmed. So there is definitely something, and this is something I've learned from an endocrinologist as well. Well, the uncontrolled hypothyroidism can give rise to a host of problems in the baby, as well as during the pregnancy: miscarriage, anemia, intrauterine fetal demise, stillbirth, and preterm delivery, low birth weight. Of course, preeclampsia is also there with hypothyroidism, and developmental anomalies, including reduced IQ. So maternal and congenital hypothyroidism can result because of severe iodine deficiency. And this I've already kind of mentioned. And this is why it's so important that we pick up these cases of subclinical hypothyroidism, so that we don't end up, having a problem with the baby. Especially, nobody wants a mentally retarded baby or something like this in the era of 2021. Well, something which is very important for us to note, that the American Association of Clinical Endocrinologists always say that we must use a high quality brand preparation of thyroxine, which is available, and it's preferable to continue the same brand of levothyroxine throughout treatment. Like, you start L-troxin, you stick with L-troxin. Don't start jumping with brands, because now we have quite a few. When we were PGs, I think the only one we knew was L-troxin. So now, of course, there are so many other companies which come. Importantly, patients should be re-evaluated and reiterated that the interval at least 6 weeks following any change, we must be extremely careful that if there's been any change. And as mentioned, that the American Thyroid Association, they recommend for patients who have started receiving L-thyroxine and who've had their dose, type, and brand change, the TSH function should be measured again after 8 to 12 weeks. Well, this is the other similar kind of a hypothyroidism pathway, the algorithm, which was similar to the one I showed for the hypothyroidism. All of you can just take a screenshot if you wish, and because then we'll really go way above our time given to me by Dr. Pratik Tambe for my presentation. So the call of the day is appropriate treatment, and more importantly is awareness. We must test for the thyroid profile in pregnancy. We must make an effort to ensure that we motivate. Everybody thinks about the cost, but we have to look at what is the risk-benefit ratio and the cost-benefit ratio in any field. That if we do not do this test and we end up with a problem, what are we going to face? And if we don't spend now, what are we going to spend later? So these are some of the things which we have to think about it. So it's all of us who have to counsel our patients regarding it. So few clinical practice pearls as far as the hypothyroidism, and of course, these are the two topics which I did not touch upon because it's beyond the scope of the presentation. For hypothyroidism, of course, we know that T4 is essential for early fetal development. Little T4 crosses the placenta after the first trimester. Adequate treatment, we have a good outcome, as we know, and this is the commonest of the lot. That's why I've kept it right in the front. As far as hypothyroidism, we have to ensure that we do not overtreat, and we should not start very, very early treatment, because then we can end up in trouble if it's really not very, very severe. And we must, I repeat, involve an endocrinologist in this, because they are the ones who are very, very knowledgeable about it, and don't try to do things on your own and land up in trouble. And of course, postpartum thyroiditis is something which is also important. It occurs about 3 to 4 months postpartum. It's an autoimmune problem, and it can be only picked up with, of course, the tests. Thyroid nodule and cancer is beyond the scope of this presentation. So I would really thank all of you for giving me this opportunity. It's a vast topic. Speaking about it in 20 minutes, really, I will not be able to. I know I could not maybe do proper justice to it, but this is just to give you a glimpse of what we should, as clinicians, and more importantly, as postgraduates who have logged in, should think about whenever a question on thyroid disorders in pregnancy comes along. Thank you very much for this opportunity, and thank you for your time, and thank you for your patience.
Thank you, Professor Krishnendu. That was an excellent overview of a very important and very, very practical approach to thyroid dysfunction. And I think we have learned many a point today which will help our patients achieve, entitled to better care. So thank you so much, and over to you, Pratik.
Thank you very much.
Thank you, Pratik. Sorry.
Thank you very much, sir, for being here. Really appreciate it. We know you're extremely busy, and we hope to see you at the SAPOC conference this weekend again. Thank you for taking time out from your busy schedule to spend time with us. We have nearly 1,200 registrations for today's event, and we are really privileged to have this galaxy of stalwarts here amongst us. I would request Dr. Rahul Mani to introduce our next speaker, Dr. Rajendra Nagarkatti, please.
Good afternoon, everyone. Thank you for inviting me here as a chairperson. It is my pleasure to be with Thana Obstetric Gynec Society for AMOG's Endocrinology Committee. Dr. Rajendra Nagarkatti is a chairperson of Foxy Midlife Management Committee, chairperson of the AMOG's Midlife Management Committee. He is an executive council member of the Mumbai Obstetric Gynec Society. He is the founder secretary of the ISOPAth Mumbai chapter, past president of Association of Fellow Gynecologists. He is a joint treasurer, Association of Medical Consultants Mumbai, past president IMA Mira Bhayandar branch, past president Bhayandar Medical Association. So he has held a lot of responsible posts throughout Mumbai and suburbs of Mumbai. He runs the Ashirwad Maternity and General Hospital at Bhayandar. He is attached to the Vokad Hospital and consultant obstetrician and gynecologist at there. Then he is also attached to Bhimsen Joshi Municipal General Hospital at Bhayandar, and also an IVF consultant at Prophet IVF Center, Kandivali. Over to you, Dr. Rajendra.
Thank you, sir, for the kind words. And just a small correction, I've just handed over my post of chairperson of the Foxy Midlife Management Committee. But it was wonderful being there for 3 years and working with Foxy. I wish to, at the outset, thank my dear friend, Dr. Pratik Tambe, chairperson of the EMOG's Endocrinology Committee, for inviting me today to speak on this very important topic today. And it's indeed a pleasure to be here with all of you, with Professor Krishnendu Gupta, with Dr. Kavita Bapat Madam, who's a special and dear friend. Ma'am, it's such a pleasure to have you here as guest of honor to bring your positivity always. So thank you. And I also wish to give regards to my mentor, Dr. Rajendra Singh Pardesi sir, and all the other chairpersons, Dr. Parul Kotadawala, Dr. Amay Purandare, Dr. Rahul Vani, as well as Dr. Ragini Agarwal ma'am and others. So let me now begin screen sharing. I think I had to give my regards to everyone because there are such esteemed faculty here today. So pardon me my 2 minutes. Yes, so the screen share is not, the slideshow is not starting.
So you can just hit F5 on the keyboard.
Which one?
F5.
F5.
Yes, sir.
So may I request you to click once on the screen and then go to the bottom. The bottom, you will see the slide option, sir, towards your right.
I mean, I'm not, the slideshow option I'm not getting.
Yes, sir. That's the fourth icon after the notes, sir.
It's probably covered by the toolbar. That's why I've
Okay.
Yes,
sir.
Okay.
Fantastic. Please go ahead.
Okay. Yeah. So the topic given to me is menopause, making the transition, which is a slightly different topic, but very, very relevant and very important, I think. Bring you greetings from the EMOG's Midlife Management Committee, myself as chairperson, Dr. Nandita Palshetkar, President EMOG's, Dr. Arun Nayak, Honorary Secretary EMOG's, and Dr. Bipin Pandit, Treasurer EMOG's. William James Mayo said very rightly that the glory of medicine is that it is constantly moving forward and that there is always more to learn. And the ills of today do not cloud the horizons of tomorrow, but act as a spur to greater effort. And that is what is so very necessary in management of our menopausal women, and especially the ones who are making the transition. Now, we all know menopause is a universal and a natural event for women. So why does it need treatment? Well, it's because of this transition. That is, a woman is moving on from a very active lifestyle into something which is suddenly bringing about symptoms, bringing about changes in her life. And that is sometimes the woman is not able to cope with it. And that is where she needs our help. The menopausal transition or the perimenopause is the period that links the woman's reproductive years and menopause. It is the sort of the transition between the reproductive age to the menopausal age. And it is during this transition that women often have menstrual irregularities. They have vasomotor symptoms like hot flashes. They have vaginal dryness. They have sleep disturbances and also psychosomatic problems. Perimenopause is different for different women, but on an average, it lasts somewhere between 3 to 5 years. Now, we all know the protective effect of estrogens. It facilitates reproduction. It increases the lean body mass. It reduces abdominal fat. It improves insulin resistance, decreases the LDL-HDL ratio, decreases blood pressure, maintains bone density, a very important action. It improves mood and sleep quality. It reduces skin wrinkling, again, a very important aspect for women. It maintains cognition, improves appetite, maintains gut microbiome, and very important, maintains the immune system and modulates inflammation. So therefore, moving. Yeah. So therefore, these are the consequences of menopause, which are due to estrogen deficiency. There is obesity, there is disturbed sleep, mood disorders, metabolic syndrome and diabetes, osteoporosis, cardiovascular health and atherosclerosis, Alzheimer's disease, breast cancer, fatty liver, GI disorders. All these are the consequences of menopause, and which are all due to estrogen deficiency. And these are the symptoms specific to the transition phase, that is the perimenopause. That is a higher vulnerability for psychiatric problems and a generally poor quality of life. Aches and pains, myalgias, fatigues, etc. Physiological symptoms like hot flushes, night sweats, nighttime awakenings, etc. Sleep disturbances, sexual arousal disorders, loss of libidos, etc. Urogenital complaints. Then again, irritability, anxiety, low libido, all these are part of the gamut of symptoms that happen in perimenopause. So basically, what happens in our life is there is a change of life from the play mode to the pause mode. And it is our duty as gynecologists, as their physicians, to see that they continue to remain in the play mode, to continue to remain to enjoy life and have a better quality of life in this phase. And why do we need to do this? Because there are many learned women, but many people know what they do, or rather know what to do, but few do what they know. And therefore, it is important for us to guide them. This is the epidemiology, that women live nearly 1/3 of their life beyond menopause. The longevity of women has increased, and therefore, a menopause is almost a 1/3 part of their lives, a very significant part of their lives. And so you just cannot say that, my life is over and let me just face whatever is coming to me. No, I think this particular concept needs to be addressed to by us, that they understand that this is a major part of their life which they need to enjoy. In 2000, there were estimated 31 million women who reached menopause, and by 2022, it is estimated that 48 million women would reach menopause. So be ready to cope up with the problems. It's of course a big challenge for all of us, but something that we should be able to address. Menopause present status, as I said, it was always believed to be the beginning of the end, but now no, it is the beginning of a new phase, that is the middle age of successful aging in urban India. In fact, that is, I think, precisely the reason why Foxy also named it from the menopause committee to the midlife committee. So that is again a positive step by Foxy. This is again a classification of the stages of menopause by none other than our iconic former president of Foxy, the late Dr. Bhairam Ankleshwarya, who classified it into stage 1, stage 2, stage 3. The stage 1 is the one roughly 3 to 5 years before menopause, that is the pre or the perimenopause, which again was divided into 1A, that is menstrual irregularities, 1B, that is vasomotor instability, and 1C, that is the early psychosomatic symptoms. The action that we need to take at this stage is, as you can see here, it is established communication. That is what we need to do, is give them counseling, make them understand that this is a part of their life which they need to address, which they need to enjoy equally as much as the part that is over. The second phase, that is the part 2, the early 2A, is the 1 year after menopause, that is the menopause confirmation, because we all know for diagnosis of menopause, it is an absence of menses for 1 year. So this is when there is a confirmation of diagnosis and just the beginning of early symptoms. The stage 2B is up to 5 years after the menopause, where there are local atrophic changes, there are late psychosomatic symptoms, and we need to treat them, of course. The stage 3 is from 5 years after menopause up to lifetime. And here you have all the late atrophic changes, the other cardiovascular and the metabolic syndromes, that is ischemic heart disease, osteoporosis, sometimes diabetes, sometimes cerebrovascular accidents, Alzheimer's disease, cognitive function disorders, etc. And important here again is that we need to prevent this. Of course, we need to treat it also if they develop it, but important is to prevent it. Now, when is treatment required during this particular phase? In the first part, that is the premenopause, treatment is necessary for vasomotor symptoms, for sleep disorders, for mood changes. Then again, between 40 and 50 years, it's required if they have menstrual disorders, especially if they have heavy menstrual bleeding, etc. And this is a window of opportunity for the early menopausal symptoms. The 50 plus onwards, that is the early menopause, sometimes you need treatment for vaginal atrophy, for dyspareunia, for skin atrophy, etc. And a lot of advent has been made in the management of this, as will be vouched by Dr. Ragini Agarwal ma'am, who is doing a lot of work in this area. The 60 plus group, there is osteoporosis, atherosclerosis, coronary heart disease, cerebrovascular disease, again, which requires treatment. First, of course, would be to try and prevent it. But then if you do have the conditions, one needs to treat it. So therefore, the management of menopause, there is hormonal therapy, which can be oral. It can be transdermal in those who are contraindicated for oral therapy. Then there are the vaginal local, that is the vaginal creams and gels. There are estrogen implants. There is estrogen intranasal. And then, of course, there is progesterone, which is for the protective effect on the endometrium. Then there is lifestyle modifications. I think that is the first thing that should be offered. And then, of course, there are other medications other than the hormonal therapy. There is Tibolon, there is SCRMs, bisphosphonates, and then there are the SSRIs and the SNRIs. And also there is the complementary and alternative medicines, which is again forming a large chunk of patients who prefer to use these complementary medicines because of the fear of MHT. So therefore, there are the natural extracts like the black cohosh extract, the isoflavones, etc. There is naturopathy and there is acupressure. So therefore, to begin with the lifestyle changes, these are some of the important guidelines given by the Indian Menopause Society in 2019 in terms of diet: to consume 500 to 600 milliliters of milk or curds in low fat, of course, to build on the calcium bank in the bones, support it with a lot of vitamin C rich fruits, vegetables to favor calcium absorption, decrease caffeine intake to less than 3 cups per day, that is a limit of 200 milligrams per day. Daily salt intake should not exceed 5 grams. Limit alcohol and avoid tobacco, regular exercises, and a good protein intake for muscle development should be at least 1 gram per kilogram body weight per day. So this is a very wonderful picture for prevention of osteoporosis, another morbidity causing condition in this age group, and therefore do adequate exercise, eat healthy in the form of good milk, cheese, cereals, non-vegetarians like fish, etc. Stop smoking, have adequate quantity of milk, and again, very important, have adequate sunlight so that you have the natural vitamin D to build up on your calcium. Then physical activity and health. Physical activity can bring about a lot of positive things. It can reduce so many chronic diseases. It promotes weight control. It slows down the premature aging, and it improves quality of life. This particular sentence is so important, that physical activity is not a panacea for all medical conditions, but it definitely and probably is the best single thing that a person can do for their health. These are all the benefits of exercises. It increases bone density, it increases muscle strength, improves posture, flexibility, endurance, it improves quality of life, decreases the risk of falls, and decreases pain. Now coming to MHT, what we need to do is balancing act. That is, you have to do the balancing act between the pros and cons. MHT should not be recommended without a clear indication of its use, and healthy asymptomatic women at menopause transition do not need MHT. So therefore, what we need to do is advise therapeutic lifestyle modifications, give them proper counseling, and write a prescription for nutrition, for exercise, and also, yes, for screening tests for cancers along with your routine lab tests. Now, what are the actual indications? So of course, yes, if don't use it unnecessarily, but yes, for specific indications, you should definitely use MHT. So for symptoms like vasomotor symptoms, it has proven its superiority in terms of relief of symptoms over all the other drugs and modalities. For genitourinary syndrome of menopause, again, it is very beneficial. Prevention of bone, here most often it is a vaginal cream which is useful. prevention of bone loss, especially in women with high risk of fractures, one should use MHT. And of course, in prevention, in premature ovarian insufficiency, which could be either surgical, it could be autoimmune, it could be idiopathic, it could be chromosomal, or it could be post-radiation. Here again, one should use MHT, generally continue till the age of natural menopause. Yes, we all know that there are concerns about MHT. There is increased risk of cardiovascular morbidity and mortality. There is increased risk of VTE and stroke, increased risk of some cancers like breast cancer, endometrial cancer, ovarian cancers, etc. And so therefore, one should know the contraindications to MHT. One is undiagnosed abnormal bleeding in the venous thromboembolism patients, active or recent MI, suspected or current or past history of breast cancer. Then again, patients of endometrial cancer or any other estrogen-dependent cancer, patients with active liver disease and abnormal LFTs, and patients with uncontrolled hypertension. So, yes, we should know the contraindications, but very important to know the benefits. So therefore, wherever it is indicated and wherever there are no contraindications, one should give the patients the benefit of the MHT because it improves quality of life. It can be prescribed to enhance mood in patients with depressive symptoms. The effect appears to be greater for the perimenopausal symptomatic women rather than the postmenopausal women, probably because they are already too advanced into the depression that it becomes difficult to treat them. Decreases the risk of type 2 diabetes, decreases abdominal obesity. It has a protective effect on bones. It's an absolute grade B evidence. It benefits the verbal memory and therefore lesser chances of dementia, etc. And it reduces the neovascular macular lesions. These are the NAMS, that is the North American Menopause Society guidelines on HT, that HT is very appropriate for the treatment of vasomotor symptoms in women who are considered low risk for CVD and where there are no personal history of hormone-dependent cancers. It is also the most effective treatment for prevention of bone loss and decreasing fracture risk. Studies support a decreased cardiovascular morbidity and mortality and decreased overall mortality in women taking HT with initiation aged less than 60 years and less than 10 years from menopause. And the goals, therefore, is to remove the fear of hormonal therapy and encourage individualized shared decision-making. So that line is very important. And that is where this particular saying by William Osler is so important, that if it were not for the great variability among individuals, medicine might have as well been a science and not an art. So therefore, it's necessary to individualize treatment. Therefore, the window of opportunity is something that we should identify. The target population for initiation of hormonal therapy is usually within 10 years of menopause or less than 60 years of age. HT initiated in early menopause is definitely safe. And like all other medicines, HT needs to be used appropriately. But it is essential that women in early menopause who are suffering menopausal symptoms should have the option of using MHT. Therefore, it should be the right woman at the right age, the right hormonal therapy, the right dose, and the right route. The right woman, there are 4 categories. One is the healthy one, where you can definitely and easily, safely give them. Then B is healthy with risk factors for disease. C is healthy with latent disease, that is early disease, and D is with comorbidities. So for the B, the C, and the D categories, we have to you have to weigh the risk versus benefit ratio. So this slide says it all, that a woman aged less than 50, the benefits of hormonal therapy far outweigh the risk, and therefore HT should be offered. Women between 50 and 60 with menopausal symptoms, again, the benefits of HT outweigh the risks and HT should be offered. Women beyond 60, the benefits of HT equals the risk, and treatment should be individualized with proper counseling, I would say. And finally, women aged more than 70, the risks tend to outweigh the benefits, and therefore HT should not be offered. These are all the dosages, beginning from conjugated equine estrogens, which we generally don't use nowadays. And then we went on to estradiol valerate, and then we came on to the active form of estradiol valerate, that is the 17-beta estradiol. And then the latest, that is the transdermal gel, which is very, very effective. These are the dosages, which I won't go into the details. Synthetic estrogens, the relative potency for receptor affinity is 20,000. It is which is comparable to just 100 of estradiol and just 10 of estrone. So it's much more potent than the natural estrogens. It's almost 1,000 times more potent, and it enhances the effect, hepatic effects. And therefore, synthetic estrogens are not used for MHT. It's the bottom line. Non-oral routes are sometimes indicated. So transdermal estrogen has a neutral effect on triglycerides and on the sex hormone binding globulin. So therefore, it would be specifically indicated in patients with hyperlipidemia, with increased C-reactive proteins, with migraine, with diabetes, then in patients with controlled hypertension, existing gallbladder disease, obesity, smoking, previous VTE, varicose veins, as well as, of course, for personal preference, the non-oral routes where you can either go in for the gel or you can go in for the implants or the patches. Progesterone is something which is, again, very much a part of MHT, necessary to be given along with estrogen in all women with the uterus, and wherever there is residual ovarian tissue, like in endometriosis or in frozen pelvis patients, in endometrial cancers, or where you have left behind some residual endometrium. And the choice of different progesterones would be dihydrogesterone, micronized progesterone, LNG-IUS, or the medroxyprogesterone acetate. These are the different doses. Again, I won't go into the details. Then you have the SERMs, the selective estrogen receptor modulators. The SERMs that are normally used are raloxifene. Then there is the new drug that is bazidoxifene. Then there is ospemifene, which is again not yet available in India. And there is ormiloxifene, which is a very wonderful drug, an Indian origin drug, which is used quite often. Then you have the STEER, that is the selective tissue estrogen receptor activity regulator, that is Tibolon, again a wonderful drug. And then there is the new combination drug, that is the tissue selective estrogen complex, which is a combination of conjugated estrine estrogen, equine estrogen with bazidoxifene, which is sort of using the best of both worlds. Tibolon is a wonderful drug, a synthetic steroid, in essence a progestrogen, but post-absorption it has estrogenic, progesterogenic, and androgenic properties. The estrogenic properties are mainly beneficial in terms of bone, brain, and vaginal tissues, and are responsible for control of the vasomotor symptoms and prevention of bone loss. The progesterogenic and anti-estrogenic actions are seen on endometrium and breast, which makes it a very much positive sort of feature. And then the androgenic actions are on the mood and libido. So therefore, it's very, very useful in patients who have loss of libido or who have sexual problems. Not recommended within 1 year of menopause because of the risk of causing irregular vaginal bleeding, but especially 4 or 5 years after menopause, it's a very, very wonderful drug. Specific indications I have mentioned: mood and libido changes, older women. Then comes the TSEC complex, which is a combination of conjugated equine estrogen with bazidoxifene. Bazidoxifene is a third generation SERM. It has antagonistic action on the endometrium and breast. And when used in combination with the conjugated equine estrogen, it gives a blend where it is beneficial on the vasomotor symptoms, at the same time safe on the endometrium and on the breast. There is generally no need to use progesterone. Progesterone causes bleeding and has side effects. This TSEC complex has been approved by the FDA in 2013, but yet not available in India. The dose of CEE is most commonly 0.45, and that of bazidoxifene is 20 milligrams. It's specifically approved for the treatment of VMS and osteoporosis.
Sir, just
yes?
2 minutes to go, sir, if I may request you to kindly.
Oh, yes, yeah.
Thank you.
How is it given? These are the different regimens. We all know the continuous sequential, continuous combined, and the only estrogen in patients who do not have the uterus. Therefore, it's important to individualize the treatment depending on the circumstances. Then comes to the genitourinary syndrome, where vaginal estrogen therapy or the local estrogen therapy is most beneficial. Generally used for vaginal symptoms like dryness, itching, burning, dyspareunia, and symptoms of vulvovaginal atrophy. Also for recurrent urinary tract infections, especially frequency, urgency, etc. Overactive bladder, vaginal surgeries. You can give it pre or post-operative in vaginal surgery, especially in the peri or the postmenopausal women. And if there are associated sexual dysfunction, then along with the vaginal estrogen therapy, you can add oral tibolone in a dose of 2.5 milligrams per day. These are the vaginal preparations available in India. There is Primarin available as 1 grams containing 0.625 milligrams. Estriol or Evolon cream contains, again, 1 gram contains 1 milligram of estriol, generally given as 0.5 to 1 gram per day vaginally at bedtime for 2 weeks, and then followed by twice a week application. Routine endometrial surveillance is not needed, and again, progesterone protection is not needed when using the vaginal preparations. So what should we do after today, especially after the Independence Day of 15th August? Get past the misinformation and hysteria that resulted from the WHI trials and stop denying potential benefits, that is vasomotor symptoms, fracture, CHD, dementia, to the women who can be helped. Secondly, HRT is appropriate for symptomatic women who have no major contraindications, and a good evidence from 50 years of observational studies and clinical trials suggests that benefits outweigh the risks when started early, within 10 years of menopause or within 60 years of age. And to end, I would just quote Angelina Jolie that I am now in menopause. I will not be able to have any more children and expect some physical changes, yes, but I feel at ease with whatever will come, not because I'm strong, but because this is a part of life and it is nothing to be feared. Thank you for a patient hearing, and sorry if I've gone up over the time by a few minutes. Thank you.
Dr. Rahul, sir, please unmute.
Thank you, sir, for a very, very elaborate talk. Menopause is a challenging subject and as well as challenging to speak in 20 minutes, but you have very well covered it with all types of treatment, and I think it was a very, very nice talk. Thank you. Thank you. Over to you.
Thank you, Dr. Nagarkatti, sir, and Dr. Rahul Vani, sir. Fantastic session. And we have one speaker yet to go, and we have nearly 1,300 odd registrations for today's event, which is an amazing number. I would request my dear friend and colleague, Dr. Amay Purandare, sir, to introduce somebody who you will not believe is actually our senior, Dr. Sandhya Saharan, President of the Thane OB-GYN Society.
Thank you, Pratik. It gives me great pleasure that I've been told to introduce one of my most favorite seniors, Dr. Sandhya Saharan. Dr. Sandhya Saharan is at present the president of the vibrant Thane OB-GYN Society. With all the enthusiasm and the dynamism and the inspiration that she brings to the Thane OB-GYN Society, I see the Thane OB-GYN Society grow from strength to strength. So congratulations, Dr. Sandhya, for the great work you are doing with the TOGS. Dr. Sandhya is a consultant OB-GYN with special interests in endoscopy, infertility, and yoga. She is attached to Jupiter Hospital, Thane, to the LH Hiranandani Hospital, Kausalya Medical Foundation, Cure IVF, and Birthing Hospital. Dr. Sandhya is one of the very well-known members of our department at KEM, and has always had a very excellent academic career, and was awarded the Young Scientist Award in 1994. She has also been the recipient of the H. Disa Silver Jubilee Award in 2001, the best paper in the International Congress on Infertility in 2003, the Bharat Jyoti and Best Citizen of India Award in 2007. Sandhya has devised normograms for labor monitoring and has been a keen Rotarian. And there is a creative side to Sandhya as well. She is an excellent singer and a dramatist. So over to you, Sandhya. It gives me great pleasure to have you in AMOGS, because you have picked my brains to no extent when I was the secretary of AMOGS and Thane wanted to get affiliation into AMOGS. And I'm sure that this affiliation happened. And I'm very happy that we were successful in the project together. Over to you, Sandhya.
Thank you. Thank you so much, Amay, for the kind words. And yes, it is thanks to your spontaneous and absolutely promptness that we are part of AMOX. I wish to thank AMOX President, Dr. Nandita Palshetkar, again a dear friend of mine, Pratik Tambe, for remembering me, and for the entire team who is always there with us, and for this illustrious co-speakers who I'm sharing the platform with. Thank you for this opportunity. And as Rajendra Nagarkate has just told us that menopause is a huge topic to be covered in such a short time, I hopefully have a small topic which I will cover in a very short time. So rest assured, we go quick to managing UTI in current practice. So as we all know, urinary tract infections causing an inflammatory response, second most common infectious presentation in community practice, and diagnosed in outpatients as well as hospitalized patients, mostly self-limiting, but sometimes cause a recurrence and can occur in all age groups. So this is something very important to be remembered. And the definition, asymptomatic bacteriuria, is basically isolation of specified quantitative count of bacteria in appropriately collected urine sample, that is the midstream sample after cleaning the urethra, and in a person without symptoms or signs referable to a urinary infection. 2 consecutive voided urine specimens, bacterial strain of greater than 10 raised to 5 CFU per ml. Uncomplicated acute urinary tract infections are symptomatic bladder infection characterized by frequency, urgency, dysuria, suprapubic pain in a woman with a normal genitourinary tract, and is associated with both genetic and behavioral determinants. This is from the IDSA guidelines. Now, why should we be concerned? Because worldwide, it is 150 million cases per year, 90% of cystitis, 10% pyelonephritis, 75% are sporadic, 25% are recurrent, and 2% are complicated. Every woman will have at least one UTI in her life, or at least half the women will have so. And this increases after menopause, and after one UTI, 20 to 40% will have a recurrence, and they are basically reinfections. Now, the classification can be upper or lower. Basically, urethritis is mostly associated with STDs. There can be cystitis, and the symptoms can be the same in all patients, or they can be asymptomatic, sporadic if it is less than one UTI in 6 months, and recurrent is more than one UTI in 6 months, complicated or uncomplicated, asymptomatic bacteriuria or pyelonephritis, intrarenal and perinephric abscesses are upper UTIs. Now, diagnostic evaluation, as we all know, history is the mainstay. If a patient is asymptomatic, it's a different story. But in a symptomatic patient, especially in these days of COVID, when the patient is unable to come to the hospital or get tests done, then a history alone can give you a clinical diagnosis, and you may treat the patient on the telephone itself. And chemical tests for the presence of bacteriuria can be by urinary dipsticks, pyuria on microscopic examinations, urine WBC counts. A count greater than 10 raised to 5 per ml is what we generally consider as standard, but up to 10 raised to 4 or even 3 is accepted as significant if the patient is symptomatic. Contamination of the sample is something which we need to look into very closely to avoid a misinterpretation in the report. So midstream sample in a sterile container is what we recommend. Measurement of the urinary enzymes. We have urinary nitrites in the urea splitting organisms that is to be measured. Measurement of C-reactive proteins, antibody responses to the bacteria. In cases where you do not understand and you suspect structural abnormalities, or there is a lot of post-void urine, you can do an ultrasonography. You can also do a CT scan in cases which are more complicated or who have had urological interventions, and MRI with contrast imaging is also of great value. Now, the microorganisms, largely we have the E. coli. Basically, it is a GI tract organism. It is responsible for 80 to 85% of UTIs, and Staphylococcus saprophyticus for 5 to 10%. We also have Klebsiella proteus, Pseudomonas aeruginosa, Rare is viral or fungal agents. Most common fungal is Candida species. And patients who have an indwelling Foley's catheter who are receiving broad spectrum antibiotic therapy, or patients diabetes mellitus on corticosteroids. Now, this is by Ranganathan Vasudevan from the Journal of Microbiology, 2014. Now, two potential sources. What are the roots? Now, one is the hematogenous infection with seeding of the kidney during the course of bacteremia, because the kidneys receive 20 to 25% of cardiac output. Any microorganism which reaches the bloodstream can be delivered to the kidneys. The major causes of these are Staph aureus, Salmonella, aeruginosa, and Candida. Chronic infections which can affect the skin, respiratory tract, blood circulation, causing renal scarring, small abscesses, and which affect the renal tubular system and the renal papillae. Then we have the second, that is the ascending infection from the urethra to bladder and then via the ureters to the kidney. The reservoir from where the UTI pathogens emerge is the GI tract. Now in females, why do we see a preponderance of UTI is because of the short urethra, proximity to the anus, and also proximity to the vaginal opening. What is important is the ability of the host defense vis-a-vis the bacterial toxicity. Now, this is a slide which shows us the pathogenesis of bloodborne, whereas the ascending route, as we all know, the hematogenous seeding can also take place in cases with Salmonella and Mycobacterium tuberculosis. This is something which we need to remember. In our country, it is a lot of preponderance of pox, which is missed. And once in the bladder, the bacteria, they pass on to the ureters, and especially in patients who have a vesico-urethral reflux or in children who have deficient posterior urethral valves. We see that they get infected recurrently, and this goes on to the renal pelvis and damages the renal parenchyma. Patients who are hospitalized for a long time, who have indwelling catheters and who have instrumentations, cystoscopies, are also predisposed to these kind of pathogens. Now the stages is, first is the colonization. It colonizes the urethra, ascends towards the bladder. Then it is the uroepithelial penetration. It penetrates bladder and bacteria replicates, forming a biofilm. And then it ascends to the kidneys. It infects the renal parenchyma, causing an inflammatory response, and the whole thing is called pyelonephritis, and eventually it leads to acute kidney injury. Now, what are the risk factors? If it is any structural or functional abnormality of the reproductive tract, it's very important. I always insist when a patient comes with a symptom, many a times they go to a urologist straight away. So the urologists also do tend to refer them to us to rule out if the patient has a uterine prolapse, if she has cervicitis, vaginitis, if there is atrophy of the vaginal mucosa, if there is any discharge which is suggestive of an STD. This is very important. The sexual behavior of the patient, what kind of spermicidal jelly or a diaphragm is she using? A postmenopausal women, as we've all heard just now, they are predisposed because of the paucity of estrogen. Diabetes mellitus, of course, those who are on steroids are also immunosuppressed. Pregnancy because of the high incidence of progesterone, and those who have long indwelling catheters or who have an obstruction like a stone or a stricture. And most importantly, the host-dependent factors, which we will look into now. Now, if the host protective factors like the flushing mechanism of micturition, acidity of the pH of the urine, vaginal pH, and also the chemotactic factors, that is interleukin 8, if these are heavier or if they are more predominant, then there is no infection. But if the virulence is strong, that is the factors which complicate bacteriuria, then there is an infection. That if there is a residual urine after voiding, turbulent urethral flow, foreign bodies, atrophic mucosa, or a VU reflux, and if there is a childhood pyelonephritis, diabetic nephropathy, malignant hypertension, chronic pyelonephritis, then there is a worse prognosis. Now, clinical symptoms, it depends if it is a lower urinary tract or an upper urinary tract. If it is cystitis, then you typically have frequent voiding, suprapubic pain, burning micturition, and hematuria. Also, in some cases, if it is upper UTI pyelonephritis, then fever with chills, flank pains, costovertebral tenderness, nausea, vomiting. And in severe cases, when there is gram-negative septicemia, patient may also present with shock. If it is urethritis, then you have to ask for dysuria or frequency, suspected STDs to be ruled out, and also the kind of sexual history, as I said. In cystitis, then you have to see if there is a cloudy or malodorous urine, and if the WBC is more than 2 to 5 with symptoms and bacteria on urine microscopy. Pyelonephritis, be careful of complications, sepsis, papillary necrosis, abscess, and also renal scarring. So you have to do a detailed examination, do a urine microscopy, and look for bacteriuria, hematuria, rule out gram-negative sepsis. In severe cases, very important to do both culture, blood, as well as urine. Now, significant, as I said, if it is a midstream sample, symptomatic patient, or if the urine is in the bladder for less than 4 hours, then more than 10 raised to 4 to 5 is significant. In asymptomatic bacteria, more than 10 raised to 5. In a suprapubic puncture, any growth is significant. In an asymptomatic patient, if there is a positive urine culture repeatedly in the absence of signs of UTI, then you have to treat the patient. Any pregnant patient coming with urine infection should be treated. Otherwise, there is always a risk of getting into a preterm labor or fetal growth restriction. Cystoscopy only indicated when you do not find a diagnosis, or if the patient is coming with repeated UTIs, but definitely never in an acute onset. Non-pharmacological management, very important. Plenty of oral fluids, urinate on urge, proper hygiene, very important. Wipe from the front to the back. Cranberry juice, though not documented, does help. Vitamin C, probiotics. Avoid irritants. This is very important. We should coach our patients, do not use deos and sprays and powders. They are associated, talcum powders, as we know, are associated with CAs. Also, spermicidal creams and diaphragms can cause recurrent UTIs. If there are more than 3 episodes per year or more than 2 in 6 months, then definitely it is considered recurrent UTI, and we can consider prophylaxis in these patients. Treatment, antibiotics are the first line of treatment. Which drug? Now, it depends on the type of bacteria, the kind of sensitivity report, how is the health, the general condition, what is the virulence. Most commonly, we start with trimethoprim, sulfamethoxazole. As we all know, Bactrim was the gold standard in the olden days. Fosfomycin is a growing favorite amongst urologists and gynecologists. Nitrofurantoin is a gold mine. Will come with patients with multiple urine culture reports, resistance to everything, but somehow they're always sensitive to nitrofurantoin. And we have the cephalosporins. Next slide. Now, the 3 goals of therapy: control or prevention of the development of urosepsis, eradication of the invading organism, prevention of recurrences, and as I said, trimethoprim, sulfamethoxazole, we start with that. We reserve fluoroquinolones for later on, ampicillins, amoxicillins, and first generation cephalosporins. Second and third is always reserved for complicated UTIs, and also we think in terms of fluoroquinolones in case the others are not working. Beta-lactamases, as I said, we can have the second and third generation in more resistant form of bacteria. Beta-lactam antibiotics are used when other recommended agents cannot be used. Fosfomycin and nitrofurantoin should be avoided in patients with possible early pyelonephritis. Fluoroquinolones are typically reserved for complicated cystitis. Empiric antibiotic selection is determined in part by local resistance patterns, and they may want to limit the use of TMP SMX in order to reduce the emergence of resistant organisms. Next slide. Now, this is a flow chart for evaluating the UTIs. In a case of a clinical presentation of acute onset of symptoms, if the patient is otherwise healthy and not pregnant, consider her as an uncomplicated cystitis. No urine cultures needed. You can treat on the phone. A patient with unclear history or risk factors for STDs, consider uncomplicated cystitis, rule out STDs, do a pelvic examination and do urine analysis and culture. In indwelling catheter patients and all other patients, then you may remove the catheter, change it, do a urine culture, do blood cultures, and if the patient is going into sepsis, then you have to treat accordingly. Now, in acute onset, if there is back pain, nausea, vomiting, fever, and the patient is otherwise healthy and who is not pregnant, then you consider it as uncomplicated pyelonephritis, treat accordingly. All other patients consider as pyelonephritis, do blood culture, urine culture, and if there is a non-localizing of the symptoms, patients with systemic infection, then you consider it as a complicated UTI or pyelonephritis and rule out other possible etiologies. And also in patients when there is asymptomatic bacteriuria who are persistently having a culture report positive, or in patients who are going to be for a renal transplant or invasive urological procedures, then you have to treat them with other higher antibiotics. Now, these are the antibiotic regimes which are there. The first treatment of choice, as I said, trimethoprims, then you can go on to amoxicillins, then nitrofurantoins, and then to the cephalosporins. Now, we've all seen cephalosporins are something which we really recommend even for any surgeries, pre-op treatment as well as post-operative also, and patients respond very well to them. So I would limit my use of amoxicillin and clavulanic acid in pregnancy because it can cause NEC in the newborn. So in all other cases, we can go on with penicillins and we can also resolve them with cephalosporins. Now, limitations of the present antibiotics because of the presence of extended spectrum beta lactamases by the gram-negative bacteria and MRSA, which is a bane to all of us. So this limits the choice of antimicrobials. And you may need a longer duration of therapy, 3 to 7 days. But compliance is definitely an issue. Now, rationale for fosfomycin in UTIs, resistance of the common urinary pathogens to antibiotics is on the rise. Fosfomycin is a promising option, especially in MDR cases. There is currently no single dose oral therapy for uncomplicated UTI, and it is an effective single dose therapy. It has in vitro activity against both gram-positive and gram-negative. It is bactericidal in the urine at therapeutic doses and reduces adherence to bacteria to uroepithelial cells. Now you have therapies, a single dose, 3-day course therapy, extended course, or for 4 to 6 weeks, or prophylactic, even up to 1 year. It all depends on how the patient presents. Women who present with complaints of dysuria and frequency, short course therapy, follow them up. In case the patient is asymptomatic, no further intervention. Symptomatic patients, do a urine culture, repeat, treat accordingly until the patient is absolutely asymptomatic. You can repeat a urine culture after 10 days and then that's it. Appropriate antibiotic treatment leads to significantly higher symptomatic relief, bacteriological cure rates, and better prevention of reinfection. Usually, first treatment to be administered to patients with UTI is empirical antibiotic treatment. As we all know, UTI can be very distressing, and the agony of a person who is faced with that can only be understood by that patient. So thank you so much for a patient hearing.
Thank you very much, ma'am, for that short, sweet, and very crisp talk on management of UTIs. We have a few audience questions which have come in, and I'd just like to take them. Amma, your closing remarks, please.
Thank you so much, Sandhya, for that elaborate talk. I think urinary tract infection is a very common challenge for the gynecologists. Our patients come to us first to seek care and not to the urologist. And I think we should be very, very evidence-based and with the correct rationale of using the correct antibiotic in these patients. Also, the challenge of recurrent UTIs is coming more and more these days because of antibiotic resistance. And therefore, we should judiciously use the correct antibiotic, which may be culture-driven. And also, we must complete the entire course and not give short courses of antibiotics. Third promising therapy that is coming up is the role of probiotics, because now every disease in the body is thought to be governed by the microbiome, especially something like recurrent UTI, which happens again and again because of a change in the microbiology. And therefore, probiotics are finding their place as key adjuvants in the cure of UTI, especially recurrent UTI. So thank you so much for a very practical and a very evidence-based talk.
Thank you. Thank you so much, Amrit.
Thank you very much to all the esteemed speakers. We have a few questions which are relevant from the audience, and we'll just take them because we still have 5 minutes left. And the first of these is from Dr. Veena from Maharashtra, and this is for Dr. Nagarkatti. Thank you, sir, for sticking around for the Q&A session. And her question is, HRT can be given up to what period? Is there a cutoff limit beyond which you should not give HRT, or it's not safe anymore?
Generally, the safety limit I said is 60 years. So generally less than 60 years of age or less than 10 years after menopause, that is a safe limit where one can, I think, safely give it. And after 60 years, between 60 to 70 is, you have to individualize the treatment. If she has comorbidities or something, then probably not to give her MST. But if she doesn't have comorbidities, she doesn't have contraindications, and with proper counseling, if the patient is willing to, take it, then yes, definitely you can. But after 70, it's a definite no. So that is how I would say it in terms of age-wise.
Thank you, sir. The next question is from Dr. Jyoti, who is from Mumbai, and she's asking, OGTT is abnormal, but fasting and PPBS is normal every month. Then also should the patient be called GDM? Short answer is yes. The next question is from Dr. Lakshmi Sen, and she's from Katihar, and she's asking, how do we manage a GDM patient during normal labor, and how is the insulin dose to be titrated? I think it's the same person who has also asked what type of insulin should be used, and should it be in ringer lactate or normal saline. And for this, I have two very beautiful guidelines, which I'll just quickly share my screen, which will make my job very easy. So the first of these is from the National Institute of Clinical Excellence, or NICE. This is the NICE guideline which was published on GDM. I hope we can see the screen. And it says very clearly that you should monitor your capillary glucose when women with diabetes are in labor. It has to be between 4 millimoles per liter and 7 millimoles per liter. For those of you who don't know the conversion, because we follow milligrams per DL in India, the conversion is multiplied by 18, and therefore 4 becomes approximately 70 and 7 becomes approximately 120. For women who have type 1 diabetes, you should start them on intravenous dextrose and insulin infusion right at the onset of established labor, and then you try and titrate the dose accordingly. If you further want to go into the details, this is the Government of India guideline, which is there on the GOI website. If you can't find it, please send me an email. I'll be happy to share it with you. IV infusion with normal saline and plain insulin to be started. If your starting level is between 90 to 120, you don't need any insulin at all. Between 120 to 140, it's 4 units. 140 to 180, it's 6 units. More than 180, it's 8 units. And the rate of infusion has to be 100 ml per hour or 16 drops per minute. This is a very simple, easy sliding scale. This is also followed by intensivists and internists. So if you have a physician who is attached to your hospital, always refer, make sure that he sees the patient at least once in labor. Short and sweet and very to the point. Yes, please go ahead, Amit.
Pratik, if you remember, we were taught by Shashank Joshi the rule of 100. Yes. That the the sugar levels anytime during labor should always be more than 100. Okay. You should infuse not more than 100 ml of dextrose in an hour. Okay. Obviously, the glucose insulin drip was the one that we commonly use because it's a good balance. It's called as a neutralizing drip. Okay. And last but not the least, that you should not give, or you should be worried if you are giving more than 100 units of insulin in a day. So this was the rule of 100. I think Sandhya is nodding in agreement. This is what we were taught. It's a simple way. Never let the glucose fall below 100. Don't give more than 100 ml. And thirdly, if you're giving more than 100 units of insulin in a day, this patient requires closer monitoring. Closer monitoring was the fourth criteria, that at least monitor the glucose between 100 to 120 minutes, every 100 to 120 minutes in labor in a patient who has got uncontrolled or brittle diabetes.
Thank you, Dr. Amir, for contributing those valuable clinical practice points. We have two final questions which have just come in. I was about to close, but we've got two questions which have just come in. One is from Dr. Leela Agarwal. She is asking, when do we do TSH after delivery and should we continue thyroxine after delivery? You can do it at any point up to 1 week after the delivery. And of course, you need to continue your levothyroxine. You also need to refer the patient back to an endocrinologist or a thyroid specialist who will titrate the dose appropriately. The next one is from Dr. Smita Shukla, and she's from Thane, and I think this is for Dr. Sandhya. For long-term prophylaxis, 6 to 12 months of recurrent UTI, which is the preferred antibiotic, and specifically what dose would you administer?
Yeah, preferred antibiotic can be nitrofurantoin. You can give 50 grams per day. It can be given at bedtime. Or if you're giving, even some people like to give ciproflox for a long term, 100 milligrams can be given at bedtime. So at least they say that you can give safely. You start with giving it every day for a month. And some urologists, then they say 3 times a week, maybe, for the next 4 to 5 months. So it is all individualized because we do not just give it at one stretch. We ask the patient to follow up and then we keep seeing the patient and keep the patient under surveillance. So these are
just one point I'd like to make. If we are giving prolonged or what is called as chronic suppressive antimicrobial therapy, where the nitrofurantoin concept fits in, it is mandatory to do a G6PD before we start any form of nitrofurantoin because it can accelerate hemolytic anemia, especially if you are giving it for a long term. That's why. And if
always consult your friendly neighborhood urologist. And
also, if you are going to give any fluoroquinolone, then you should check the renal function and the creatinine clearance, because even though it's an irony that they are used mainly for UTI, some of them, especially the older generation, can cause some nephrotoxicity.
Generally, nowadays we avoid fluoroquinolones, but yes, whenever we are giving any long-term therapy to any patient, it's always better to refer to a urologist, take an opinion, never start, a long-term 6 months or something on your own. It's always better to keep a urologist in the loop because afterwards, eventually, if they go to the urologist, they'll send you back saying you didn't ask us before.
And so my friendly neighborhood urologist is also my andrologist who comes for my PISA and TSA. Dr. Kandu, you will know him very well because you both practice in the same institution. Yes, sir. Go ahead.
So, Pratik, one must keep in mind if there is a recurrent UTI which is occurring every few months, then an anatomical disorder of the urinary tract, either an obstructive or a congenital one, should be looked for, because that means the stasis of urine is occurring to a greater extent or is suspected to occur, and you need to find out why this is occurring. Is it an atonicity? Is there some latent infection? Is there a diverticulum? Is there some kind of interstitial cystitis which is provoking all this?
So an IVU or a radionuclide scan typically is what would be recommended. But then that's again the purview of the urologist. Any closing remarks from anybody?
Closing remarks is that I think this series is very good, and I would compliment Pratik. You're doing a great, absolutely phenomenal job. Just about one point which that lady raised about TSH, I would like to say we always insist on cord blood TSH. Our pediatricians are very particular that the TSH, the cord blood has to be taken for that also. And regarding all other things, I think I would just say I'm thankful to all of you and looking forward to seeing you all at SAFOG again.
Thank you, ma'am. Dr. Navakatti, sir.
Again, thank you very much, Pratik. You are doing a wonderful job, and I always say that where do you get the energy and the zeal to keep on and on and on? So I think it's a great credit to you, and thank you. And we have planned to do one more together with you. So I'll be speaking to you on that later.
Yes, sir.
Again, happy to be with Dr. Sandhya Saharan again at the wisdom, no? The wisdom.
Yes, wisdom. Yes,
wisdom conference. Yes.
Too many wise people along. Pratik gets the energy from the Merc. You've seen the Merc he has. He's inside a Merc all day long. So it is like
no. This is actually an Imperial Star Destroyer from Star Wars. But let us not digress. Sir, closing remarks.
So I think I'd like to compliment all the speakers for an excellent overview. I think all of them have raised very important practical points which will benefit all the attendees. I think there are more than 1,000 of the attendees who have registered and have attended. I've already got some messages from as far as Raipur that the webinar was very good. So I think the reach is extensive. We have gone even beyond Maharashtra, and it was one of the key visions of the president that even during COVID times, we continue our academic exchange and academic dissemination. And congrats to you, Pratik, for doing such a sincere and such a diligent job in doing this week after week with all the faculty from all across India, providing such valuable inputs to all the clinicians who attend. Thank you. I think it's going to benefit the patients even in these difficult times.
Thank you, sir. And I'll just present the formal vote of thanks quickly. We have already exceeded our time by about 6 minutes. I'd like to express my gratitude to our AMOG's office bearers, our beloved President, Dr. Nandita Palchetkar, Secretary of AMOG's, Dr. Arun Nayak, the ICOG Chairperson, Dr. Uday Thanawala, Secretary of ICOG, Dr. Ashok Kumar. Thank you for the ICOG credit point. Our guest of honor, the dynamic, vibrant, and ever zealous Dr. Kavita Papat, graced the occasion. We had 4 eminent chairpersons, Dr. Rajendra Singh Pardeshi, our Vice President of AMOGS, Dr. Parul Kuttadawal, Vice Chair of ICOG, was stuck in an emergency and unfortunately could not join. We present apologies on his behalf. Dr. Amay Purandare, sir, recently elected the 2nd Vice President of AMOGS. Thank you so much for being here right till the end. Dr. Rahul Bani did an excellent job, President of Navi Mumbai Society. Thank you so much, sir, for being there. 4 eminent stalwarts from different parts of the country graced today's event. Dr. Ragini Agarwal, Vice President Foxy, Dr. Krishnendu Gupta, past Chair of the ICOG, Dr. Nagarkatti, Chairperson for the AMOG's Midlife Management Committee and the immediate past Chair for the same committee for Foxy, and Dr. Sandhya Saharan, the President of the GYN Society. We have nearly 1,300 viewers for today's event. I must place on record my gratitude to our scientific partners, Science Integra, for doing a wonderful job. Subbu, Seshan, Shrimon, all of you do a fantastic job. Thank you for being our backbone. And last but not least, our academic partners for today were GSK, because of Eltroxin, CCM, Septum, and Superset, as you saw. Thank you so much for partnering with us, and we hope to continue this association with you in future as well. Goodbye, God bless, take care, and see you very soon at the next event. Bye for now.